Hello friends, hi, this is Dr. Shonali Chandra. Have a look at the first question which came for your exam and which was in your test. So you had to identify the causative organism, an image was given to you. Along with that, some certain clues in the question, right? So the clues were it was a foul smelling, frothy vaginal discharge, also with intense itching, and the speculum findings were given to you. So these speculum findings are showing some red dots, areas on the cervix particularly, and some part of the vagina also we can see, and there is this greenish frothy discharge. You can see it is collecting on the blades of the speculum as well. So this is what we call as the strawberry cervix, right? And these strawberry like spots can be on the vagina also. And yes, you're right, the answer is Trichomonas vaginalis. Okay, so it is trichomoniasis, right? Now, these are the sort of questions that they ask you in your exams. They could have asked you what is the diagnosis. They could have asked you which organism. They could have mentioned, they could have mentioned that what would be the investigation of choice in this situation. Yes, another question from here. What would be the investigation of choice, or a first line very basic investigation that you would do to confirm your diagnosis of Trichomonas vaginalis? What would be your investigation of choice? Yes, very good, Akash. A basic wet smear, saline microscopy would be good enough to pick up, Trichomonas vaginalis, which is a flagellated microorganism, and you can pick it up on wet smear also. So let's go through this very quick recall of a situation where a woman comes with the complaint of vaginal discharge. Okay, so when a woman comes with the complaint of vaginal discharge, have a look. Always we start with the perspeculum and perspeculum examination, and after doing the perspeculum examination, if there is any discharge found and we want to take a sample of the discharge, we do it then and there. We will not do multiple examination or multiple perspeculum, right? So we introduce a speculum, look at the condition of the cervix, look at where the discharge is coming from. If any sampling needs to be taken, take it then and there, and then complete your vaginal examination, right? So PS and PV examination. So if the discharge is coming out of the os, you have this kind of a looking cervix which looks very unhealthy, sort of bleeds on touch. Maybe there is cervical erosion there, or there is a discharge coming out of the os. We know that clinically it is looking like cervicitis. Okay, now if it is clinically looking like cervicitis, what you can do is a gram stain of endocervical smear. Now, why am I mentioning gram stain of endocervical smear? Why am I mentioning? Because this was a question asked in your exams also, and they had given you a situation where you were sitting in a peripheral healthcare center. Okay, so now I know that if you look at chlamydia and gonorrhea, the two agents of cervicitis, please remember, mark my words, if you look at the two common agents of cervicitis, chlamydia and gonorrhea. If asked a direct one-liner MCQ question, the investigation of choice is nucleic acid amplification tests, right? The investigation of choice is nucleic acid amplification test. But these are expensive. These are not available all the time, right? And even in our government hospitals, you must have seen that we are not really doing these nucleic acid amplification tests, right, routinely. So in a peripheral healthcare center, or let's say when the nucleic acid amplification tests are not available, they are not feasible to do, then a gram stain of endocervical smear should be good enough, right? So if we see WBCs there but no organism is seen on the gram stain, the presumptive diagnosis is that of chlamydia. And if we see WBCs and there is a gram negative intracellular diplococci, then the presumptive diagnosis is of gonorrhea. So remember this flow chart about the clinical diagnosis of cervicitis, and the drugs of choices are also given underneath for you to recall. Now, if the cervix is healthy and the discharge is only coming from the vagina, right? So if it's a curdy white discharge, remember here pH less than 4.5, right? You can see fungal pseudohyphae, you can see the WBCs also. Then the diagnosis is, yes, fill in the blank here. What is the diagnosis? A curdy white discharge, pH less than 4.5, fungal pseudohyphae, clear cut, na? Fungal pseudohyphae seen on again wet smear. On again wet smear, we're talking about candidiasis. Very good, candidiasis. Okay, and this we have already covered, trichomoniasis. And if there is a milky white discharge, I have moved on to the third one. I've moved on to the third box. Milky white discharge, fishy odor, no itching, pH more than 4.5, clue cells are seen and no WBCs are there. No WBCs are there. And whiff test is positive. What is the diagnosis here? Bacterial vaginosis. So, for the quick recall here, look at these. This is the diagram. Sorry, this is the image of clue cells. This is the image of clue cells. What are clue cells? What are clue cells? Clue cells are vaginal epithelial cells that are studded with gram-negative, right? That are studded with gram-negative rods, because bacterial vaginosis is actually not an STD, right? It is just altered vaginal flora. Okay, clear? So this is about the clinical presentation of a woman presenting with vaginal discharge. On this, they ask you multiple permutation combination of questions. Generally, they ask you clinical presentation to make the diagnosis. Okay, they can also ask you the drugs of choices as well. So for candidiasis, the drug of choice is fluconazole. Okay, for trichomoniasis and for bacterial vaginosis, the drug of choice is metronidazole. Okay, then another way they confuse you is they ask you in pregnancy. So please remember, in pregnancy, fluconazole you will not give. Fluconazole you will not give in pregnant women. Okay, please remember this. So if you have a pregnant woman in pregnancy and you have to treat candidiasis, then oral fluconazole you will not give. You will give vaginal clotrimazole. You will give vaginal clotrimazole. Okay, and if there is a pregnant woman and she is having trichomoniasis or bacterial vaginosis, metronidazole you can give, but preferably we are going to go for vaginal metronidazole, vaginal route of administration, be it pessaries or gels. Okay, remember this. Now, if you are treating in pregnancy either chlamydia or gonorrhea, please remember just one thing: fluoroquinolones and doxy is contraindicated. So please remember here, you can make a side note that doxy and fluoroquinolones, they are contraindicated in pregnancy. Remember this, right? So if I have to treat chlamydia in pregnancy, I can go for azithromycin. If I have to treat gonorrhea in pregnancy, I can go for ceftriaxone azithro combination. Okay, so remember this. So a lot of information gets covered in this flow chart. So we move on to the next image. Next slide. Please remember NACO kits for syndromic treatment. This is important for your INI-CET. This is important for your NEET PG, and also if anybody of you is going to attempt FMG, if people are watching this. This is very, very important. I think PSM faculty also covers it, but it is extremely important for you people to remember, right? So for cervical discharge, please remember it is the grey kit. For vaginal discharge, remember it is the green colored kit. So with vaginitis, I try to remember trichomonas vaginitis, and I try to remember the greenish colored discharge, and that is how I know it's the green colored kit. Cervical discharge is the grey kit. By grey kit, I remember gonorrhea for G and for G for gonorrhea. So I remember the grey kit is for gonorrhea related organisms, so gonorrhea and chlamydia, so it is for cervical discharge, for cervicitis basically. And if we have lower abdominal pain, if we have PID, then I remember PID and I remember pus, the yellow color of pus, and I know that the yellow kit is for the PID, right? So please remember these important pointers. If we are going for syndromic approach and we are treating cervical discharge or vaginal discharge, we should treat the symptomatic partner. And if we are going for the treatment of lower abdominal pain with kit number 6 or the yellow kit, then partner should be treated with kit 1. Okay, fine. So this is an extremely important treatment aspect. Okay, not too much is required, not so all the alternative regimes and everything is not required as far as treating genital infections is concerned. Stick to the basics and stick to what you see in OPD, stick to how you have seen these women being treated with these infections, and that is why syndromic approach becomes extremely important in our Indian scenario. Okay, so we'll move on to the next question now. Yes, 35-year-old sexually active woman visits gynae OPD for a routine checkup, and now this is mainly, the question is mainly asking about the genetics of cancer. Like, So, her mother has died of cervical cancer at the age of 40 years. What would you advise her? So, the correct answer is option number B. Okay, so first of all, remember there is no hereditary cervical cancer. Okay, we don't know of genetically associated cervical cancer. First of all, okay, the HPV related cervical cancers we know of, right? HPV infection related. As far as genetics of cancer is concerned, genetics in gynae cancer is concerned, it is endometrial cancer and ovarian cancer. Like for example, your BRCA testing or BRCA mutation. BRCA mutations are with hereditary breast and ovarian, right? So, ovarian. Okay, HNPCC, hereditary polyposis colon cancer. This is Lynch 2 syndrome. Okay, associated with which ones? Associated with which ones? Yes, endometrial and ovarian and other related, obviously, and other related, colon also, right? So, if there is a woman who has a family history of these cancers, especially hereditary gynae cancers, if they are hereditary gynae cancers, they tend to happen at a younger age as compared to the routine presentation of gynae cancers, right? So, then the hereditary testing makes sense. So, these are anyways out. Okay. So, now if you got confused between option number A and B, right, cervical cancer screening is the answer. Why? Because of her age. Okay, because of her age. She is not the primary vaccination target group. Okay, for HPV vaccination, what is the target group? Yes, what is the target group for vaccination? For vaccination, what is the target group? 9 to 14 years of age. That is a target group. This is a primary target group. Okay, this is where all the focus is. That is what it means. There is a secondary target group also. Secondary target group meaning that catch-up vaccination. Government will give catch-up vaccination drives for women between 15 to 26 years of age. Okay, so primary target group is the ones which are 9 to 14. Secondary target group is 15 to 26 years, and beyond that, that means 27 to 45 years of age. Okay, vaccine is not recommended per se. It is only in certain, high risk sexual behavior or high risk women, where case to case basis has to be seen. So, this is on case to case basis only. Alright, so she is not in the target group of vaccination strategy that is being followed in India at all. So, that is why vaccination is not the answer if you were thinking about the vaccination. Alright, fine. Now, let us have a look at the next question. Which of the following is true regarding cervical cancer screening in low resource settings? So, again, this is a previous year question from INI-CET. So, let us see if you got this question right. Yes, which is true regarding cervical cancer screening in low resource settings. Okay, when they want to ask about India, they generally frame the question with low resource settings. Okay, pap smear every 3 years starting at age 21 is not in low resource settings, no? Is not in low resource settings at all. For a pap smear to be analyzed, you need to have a lab, you need to have a pathologist and everything, right? So, it will not make sense for a pap smear in low resource setting. Okay. Co-testing is, what is co-testing? Co-testing is doing two tests together. Co-testing is PAPS, that means cytology, plus HPV. That will make the entire package of tests very expensive. So, how can it be in low resource setting? So, this is not there, this is not there. It's HPV DNA testing. See, that's how you just simply ruled out two options to begin with, right? Now, you have to choose between C and D. HPV DNA testing every 5 years. Yes, but starting at the age of 30 is your answer. Answer is option number C. Yes, visual inspection was not given, and this is what confused the whole lot of people who gave this exam the previous year, that via is not given, because again, what happens is, you people, I've seen through all, whenever I talk about cervical cancer screening, I see a lot of confusion because you read from different sources, right? And I understand that there is a discrepancy there, little bit here and there things are, because American guidelines will say something, two standard independent American guidelines also say a little bit different things, okay? WHO has come up with its recommendation way back in 2022. Now it's been quite some time, and in India we have adopted the WHO recommendations also, okay? Now, teaching cervical cancer in a rapid revision class, the whole topic I cannot teach, but I will obviously give you the key important pointers also. So, as far as screening is concerned, let's summarize, okay? What you should remember about screening for cervical cancer, okay? You should remember, must know, is what the WHO has to say. Remember this, okay? Now, in the general population, women, meaning everyday women like all of us, that means those who are average risk women, right? Screening starts at age 30, okay, according to WHO. And the test is HPV DNA is the primary screening test. HPV DNA is the primary screening test. We are also, now countries are moving towards HPV DNA testing as the main test, as the primary screening test. WHO says cost effective and affordable HPV DNA kit should be made available by the country. That is why, according to WHO, HPV DNA is now also being made affordable. Affordable self collection samples are also being promoted, okay? And it has to be repeated every 5 to 10 years according to WHO. WHO stretches it even further. WHO say 5 years, fine. It can even be stretched to 10 years. Okay, and the priority age group that needs to be screened is 30 to 49 years of age. अब आप इसको ऐसे समझो, I mean, think of it like this. We start at age 35, that means by the age of 30, we start at age 30, and by the age of 35, at least one test has been done. And then 10 years later, by the time she reaches 45, at least another test has been done. So, for one woman, that will be minimum of 2 lifetime screens, hai na, with HPV DNA testing. And that is how it is supposed to be made cost effective in low resource settings. Okay, so it makes sense what the WHO has to say. Fine. Now, also remember that what is acceptable. What is acceptable? Cytology, that means pap smear alone, is also acceptable every 3 years. Via is also acceptable alternative every 3 years, to be repeated every 3 years. So, via will be when we cannot even do cytology, when we cannot even do HPV DNA testing, affordable HPV DNA testing is also not available, like in majority of peripheral health and even community health care centers in our country. Okay, it's via. So, this is acceptable alternative as per WHO. And co-testing. WHO doesn't talk about co-testing. Co-testing is all American. Co-testing is ACOG, American guidelines, international guideline. WHO does not talk about co-testing. Okay, does not recommend doing 2 tests together for screening average women. So, co-testing, if done every 5 years. A lot of private hospitals, private practitioners in India, we're doing co-testing. Wahi chala ja raha dharra. The same thing is being done. So, co-testing is also an acceptable alternative, but it has to be repeated every 5 years. Then also remember what the WHO has to say about women with HIV, high risk women. Women with HIV, high risk women. Here we start at age 25. That is one difference. Okay, preferably HPV DNA testing, again primary HPV DNA testing, and the frequency of repeating it will be it will be more frequently repeated. So every 3 to 5 years. This is just an extra pointer. They have not yet asked about screening women with HIV or screening high-risk women. But just for a side note, you can understand that the same test can be done, but will start at an earlier age and repeat more frequently as compared to general population. Okay. So this is about your screening for cervical cancer. These are the must know pointers. Okay, and don't get confused beyond this. Now, moving on, next question. 46-year-old woman complained of postcoital bleeding and she is found to have cervical erosion on per speculum examination. What are the most appropriate steps undertaken? Now, if you've seen my rapid revision videos, okay, if you've seen them before this, a lot of my questions I try to frame around the flowcharts that I've discussed with you, so that when you go through the videos also there are questions along with that. Then I frame questions around that so that your flowcharts are cemented in your memory. That's my idea. So let's see if you knew this. Yes, postcoital bleeding, again a very specific complaint. Why specific? Bleeding after intercourse. That means it points towards something on the cervix. Right now, in the Indian context, something on the cervix causing postcoital bleeding, you should immediately think about the possibility of cervical cancer. You should immediately think about the possibility of cervical intraepithelial neoplasia. But obviously there can be other things also. It can be simply, an infection of the cervix, a cervicitis, unhealthy cervix that bleeds on touch. It could be that. Right, so it could be a sexually transmitted infection which is causing cervicitis, and that is why there is postcoital bleeding, right? So evaluation starts with a per speculum examination. Evaluation starts with a per speculum examination. Okay. If we tend to find a growth on the cervix, if there is a growth on the cervix, right? You look, you put in the speculum, there's a growth. You'll biopsy then and there, no? Biopsy then and there. Take a punch biopsy. Punch biopsy of the cervix needs to be taken. Okay, what if there is no growth? If there is no growth on the cervix, think about it. You've introduced the speculum, you know she is complaining of postcoital bleeding, you know that, and in India what happens, a lot of the times when we see these women, they are inappropriately screened for cervical cancer. They have not had an HPV done earlier, they do not have a recent pap smear, they have never been screened for cervical cancer. So first of all, one should also, in clinical practice, we tend to ask, have you, do you have a recent cervical cancer screening test result? If not, then might as well at the same time you're doing a per speculum examination, take a cervical cancer screening sample. Might as well take it then and there. Okay, now this could be whatever is available to you, a liquid based cytology, an HPV DNA testing, and biopsy will be done according to the reports. According to the reports of the initial screening test. Or a biopsy will be done if there is a growth on the cervix. So answer is option number D. Answer is option number D. Right? Fine. So please remember this. So initial after per speculum examination, look if there is a growth on the cervix, or if no growth, at least take a cervical cancer screening sample as well. But if the woman is having persistent symptoms, see, very, very important point. You've taken the screening sample. Okay, now this is my question. Right? Ritik, that is where I'm coming. HPV DNA testing done in symptomatic patient like this question as well. Yes, it is done. Of course it is. I gave you the perspective now. I gave you the perspective. Nobody is giving you the information that she has had a recent, HPV DNA testing or not. I'll justify, Ritik. That's what I'm saying. Now, if let's say you've taken the sample and the reports are negative, but she's having persistent complaints, what do you do next? What do you do next? I'll give you any impossibility of infection you have ruled out. If there was infection, you have treated the infection also. Let's assume you are maybe thinking that there is an infection. Let's assume there is a cervicitis, unhealthy looking cervix. You've given an antibiotic course also, you've treated that also, and now yet she's having persistent complaints. Sejal, post-coital bleeding, occipils, how will they help? How will they help? Occipils as a treatment for post-coital bleeding? No, you have to complete your evaluation. When I started discussing the question, the first thing I said is post-coital bleeding, look at the age of the woman. In general also, even if the age is not the this thing, in India, you see, in India, if you look at the age of cervical cancer presentations, you have to interconnect topics, my dear. All right, there is a peak of cervical cancer that we see in the women in their late 30s and 40s also. Right. So, yes, now you're thinking, Meghal and Anuj, yes, very good. So, even if the screening is a negative screening, how can you rely on a negative screening on in a symptomatic patient? By that logic, so colposcopy you will do if persistent symptoms are there. Okay, now I'll ask you one more question. And you should have asked me this question. I'll ask you one more question. Khushi Jain, you're right. It could be a small polyp also, which to the naked eye you possibly are not seeing. Maybe it's a small polyp hiding just there inside the os, and maybe colposcopy would make it visible. Yes, you good. That is also a possibility. Now, and that will be highlighted by colposcopy, because you'll be able to look at the cervix under magnification. If required, colposcopic directed biopsy will be taken. Now, the question that you should have asked me, why take the cervical cancer screening sample if the report didn't matter, and even if it was supposed to be negative, we were doing a colposcopy any which ways. So, we could have done a colposcopy straight away. Why take the cervical cancer screening sample? Yes, this question you should have asked me. Now I'm asking you. Tell me. Ritik, if the option was only of cervical biopsy, would have been preferred over D? No. Priority would have been given to the some or the other screening test. That would have been a better answer. Why did we take the cervical cancer screening sample? The answer is that we have to correlate the findings. We have to correlate whenever we have, nothing is there on the cervix. See, we started with nothing visible to the naked eye on the cervix. Okay, so you have to analyze. If you have a colposcopic impression, if you see a lesion on the cervix, okay, we have to analyze that lesion according to the baseline report, like in the sense that what was her pap smear report, was it normal, was it high SIL, was it low SIL, what was her HPV DNA test result, whether it was positive or not, right? So we have to compare our colposcopy findings with the reports of screening and then make a decision about treating the patient. That is how we do in clinical practice, okay, especially in circumstances where there is nothing visible on the cervix to the naked eye. All right. Now, if you do a colposcopy first, you're just wasting time, where you could have taken a sample in the first sitting itself, especially in our context where the women are inappropriately screened. All right. So, that is where it would have helped you, and that is why we took a sample to begin with. Okay. One could have simply not done the sample if she had a recent sample report, but generally in our country women don't. Right. Now, for endometrial cancer, generally your complaint will be abnormal uterine bleeding, heavy menstrual bleeding, and postmenopausal bleeding is particularly very, very specific. So, if you have postmenopausal bleeding, in a woman, you start by the same thing. Again, just don't think that postmenopausal bleeding hai, so it can only be endometrial cancer. No, it can be, in our context, in Indian women, cervical cancer is the most common gynae cancer. So, it can still be cervical cancer. But so you start with the pars speculum examination, same concept applies, go step by step, right? If there is a growth on the cervix, then you biopsy. Also do a PV examination also. right? Okay. Do a cervical cancer screening, work up the patient, look if there is a cervical cancer screening done recently or not, right? But your priority investigation becomes also a transvaginal sonography in postmenopausal bleeding. Okay, you can't do without a transvaginal sonography because you want to see the endometrial thickness also. Now, if on transvaginal sonography your endometrial thickness is more than or equal to 4 mm, then you also do an endometrial sampling. Then you also do an endometrial aspiration. Okay. If the ET is less than 4 mm, we can observe, especially if it is a low risk woman, I mean she does not have multiple risk factors for endometrial cancer, then you can think of observing if low risk. But if she is having persistent symptoms, persistent menopausal bleeding, go for endometrial aspiration. Okay, because endometrial cancer can arise in the background of atrophic endometrium also. Please remember this. Okay. So, this ET less than 4 mm with persistent symptoms, it will not be very reassuring. Okay. So, then you go for endometrial aspiration. On endometrial aspiration, you'll pick up something or the other. Maybe you can diagnose hyperplasia, endometrial hyperplasia. Maybe you'll pick up endometrial cancer. If you pick up nothing, then what? If you pick up nothing, if it is normal, but she's having persistent symptoms, what is the current guidelines? What do we do next? Okay, I'll give you 4 options then. Dilatation and curettage, hysteroscopy and fractional curettage, just fractional curettage only, hysteroscopy only. What? You need to biopsy. Yes, you do need to biopsy, Mansi. I agree with you. When we did an endometrial aspiration, we had gone blind with just a cannula, Pipel cannula inside and aspirated the endometrium. It may miss out certain areas of the endometrial cavity. So now best would be to go for a hysteroscopy directed biopsy or hysteroscopy plus fractional curettage, ठीक है. ये जो fractional curettage term है, ये कहाँ से है? मतलब why this fractional curettage term in current practice तो ये disregard ही हो गया. Fractional curettage we used to say back in those days when hysteroscopy was not that widely available. So we used to take the patient under GA, under anesthesia, right, and dilate the cervix a little bit and curate every nook and corner from anterior wall, posterior wall, lateral wall, and every nook and corner, and also the endocervical. When we do a fractional curettage, don't forget the endocervix also, right? So earlier we used to do that sort of fractional curettage under GA we used to do. Now it is standard is hysteroscopy and directed biopsy, hysteroscopy and curettage, hysteroscopy plus fractional curettage. So anything that is hysteroscopic guided will give us more advantage because we'll have a look inside also, right? Now, next question. 28-year-old woman is seen with complaint of postcoital bleeding and the following is seen on perspeculum examination. The lesion bleeds on touch. What is the likely diagnosis? This is a straightforward question, right? So what is this? Yes, this is a cervical polyp. So it's looking very fleshy, friable sort of a growth, very small, coming out of the endocervical area. I know it is from the endocervix because it is bright red in color. Alright, so endocervical epithelium is reddish in color. So this is cervical polyp. Most likely it is an endocervical polyp. It's not a cervical fibroid. This is not what it looks like. Cervical cancer will also not look like this. This is not a visible growth on the cervix and it's not a hemorrhagic cyst. So this is a straightforward image-based identification question. Please also see these images of cervical cancer, right? So cervical cancer could be an exophytic friable growth that bleeds on the touch. See, these words are important because they may tell you that there is a woman with postcoital bleeding and they tell you this is the finding. And then they will ask you what is the next step, or they may say it is an ulcerative growth. Then you think about the possibility of cervical cancer. They may give you the image. They ask you what is the next step. So then you have to perform a punch biopsy of the cervix. Another important thing from cervical cancer. So how somebody was asking me to revise cervical cancer. So this is how I will give you the important pointers regarding cervical cancer here and there. Okay. Now another important thing about cervical cancer is that, okay, exophytic growth can be there, ulcerative growth can be there. There's a third kind of growth, infiltrative growth. There's a third kind of growth, infiltrative growth, meaning that visibly externally on the cervix maybe nothing is there. Okay, it is infiltrating underneath the mucosa of the cervix. Interesting, it is infiltrating the growth, and the cancerous growth is infiltrating underneath the mucosa of the cervix. So sometimes to the naked eye, nothing much is visible on the cervix, or maybe some suspicious areas on the surface of the cervix, but we are not really sure if it's a frank growth, that sort of a thing. And with infiltrative growth, the clues that they will give you in the question, on PV, the cervix feels hard and nodular, stony hard and nodular. These could be the particular clues regarding the growth in the question. Now, Mohammed Rakim, why were you confused with the age? Why were you confused with the age? Age had got nothing to do with this in this question. This was a reproductive age group women. Any of the possibilities could have been there. Okay. Now, the next image, as you can see here, what is this image showing you? Yes. What is this image? On the right, this is a hysterectomy specimen. You can see here, look at this. This is the uterus sitting on top. This is the cervix that is elongated. This is the external os. Can you see? This is the external os. This is a hysterectomy specimen. So this is a cervical fibroid. This whole thing is a cervical fibroid. Okay, this whole thing is a cervical fibroid. So this is a image showing cervical fibroid. All right. And when we did basically on clinical examination, I'll tell you this patient. on clinical examination. I'm just drawing out the outline of her vagina. And when we were doing a PV, the cervix felt hard, okay, but it also felt ballooned out like this, as you can see here. Okay, this was a cervical fibroid. So this is what we call as the dome on St. Paul appearance. This is what we call as dome on St. Paul appearance. Remember this image for MCQs. And what is this? Clues. Image of a hysterectomy specimen. Look at this. This is the cervix. I marked the cervix with blue. This is the cervix. All right. Yellow line, I'm just showing that this mass was protruding into the vagina. This image will help you remember this description. There is a fleshy outgrowth coming out of the os. It feels firm. I can grab it by my hand. It is like a ball that I'm holding. I'm giving you examples. And when we try, so this is coming out of the cervix, right? And as I'm trying to move my fingers around it, I don't know how high it is coming up from. I can't reach the base of the pedicle. I don't know how high it is coming up from. Maybe something it was like this. I don't know how high it is coming from. So when you read these kind of descriptions, see, next question. 37-year-old woman, irregular vaginal bleeding, diagnosed with cervical cancer. And she has a 4 centimeter growth of her cervix and a left-sided hydronephrosis. What is the most appropriate management? Yes, very good, excellent. It is chemo radiation. Right? So in brief, what I want you to remember regarding cervical cancer, the most important thing about staging and treatment, the most important thing, obviously it is very exhaustive, but what I want you to remember is that, let's say this is the cervix and let's say this is the lateral pelvic wall, right? Now, if there is a growth here just limited to the cervix, it is stage 1. Okay, then cervical cancer spreads to the sides, to the parametrium and then down below. Okay, so this is, let's say this is the lateral pelvic wall. Let's say this is the lateral pelvic wall. LPW is lateral pelvic wall, right? So this is 2A, parametrium involved, but not up to the lateral pelvic wall, and this is 2A here. Okay, this is 2A here. That means the upper part of vagina, upper 2/3 of the vagina. Okay, this is the vagina. Okay. Now, if it is all the way up to the lateral pelvic wall, it is 3A. Lower 1/3 of the vagina, it is, sorry, ulta bol diya maine. This is 2B, sorry, 2B, parametrium, medial half of the parametrium is stage 2B, and if it is all the way up to the lateral pelvic wall, it is 3B, and lower 1/3 of the vagina, it is stage 3A. Okay, lymph nodes are stage 3C. Okay, which lymph nodes? I am talking about pelvic and or para-aortic lymph nodes. So, retroperitoneal lymph nodes. This is what I am talking about. Okay, inguinal lymph nodes are rarely involved. Inguinal lymph nodes are rarely involved, almost never involved. Okay, please remember this. All right, fine. So this is something very basic. All right. Now, also remember here, stage 2B and beyond. Stage 2B and beyond. So 2B you need to remember. What was 2B? Once the parametrium gets involved. Once the parametrium gets involved. So stage 2B and beyond, it's always chemoradiation and bulky growths. Bulky growths. What do we mean by bulky growths? Wherever you see that the size of growth on the cervix is more than 4 centimeters. Where is it? 1B3, limited to the cervix, but size of growth more than 4 centimeter. 2A2, upper part of vagina, but size of the growth more than 4 centimeter. This is how I remember the most important areas of staging. The moment you see this, right, these are situations where chemoradiation is the treatment of choice. Okay, these are the situations where chemoradiation is the treatment of choice. Remember at least this basic point. Okay, now the other important point, how did I know this was just a size just there, 4 centimeter, it's not beyond 4 centimeter. But how do I know that it is stage 3B? How do I know that it is stage 3B? How do I know that it is stage 3B? Because hydronephrosis, the ureter is traveling in the lateral pelvic wall. So, if there are symptoms suggestive of lateral pelvic wall involvement, right, please remember, it doesn't matter the size of growth on the cervix if there is hydronephrosis, which is not due to any other medical reason. Okay, and it is presumed to be because of cancer and malignancy spread. It is directly stage 3B. Doesn't matter the size of the growth on the cervix, right? So left-sided hydronephrosis could be there. She could be having flank pain. She could be having sciatica-like pain because your pelvic nerves are also traveling in that area. The lymphatics are there, so she could be having lymphedema also in the lower limbs. So these are all symptoms of advanced stage. Okay, symptoms of advanced stage. Please remember this as well. Okay, fine. Moving on to the next question. Yes, this is your most recent NEET PG question. Yes, 37-year-old comes with complaint of amenorrhea for 9 months. No withdrawal, bleeding on progesterone challenge test. Physical exam normal. Reports dryness during sexual intercourse. UPT is negative. Lab results show this and this. And what's the most likely diagnosis? Now see, there are few questions I want to discuss with you. How do you go about solving these questions? Okay. The key to these questions which have long stem a lot of information. You have to focus on the keywords, right, and rule out and eliminate options. So maybe at the end of it all, you are left with 2 choices, and that could be confusing. So this is how you approach it, because seriously, I'm asking you, and you have to answer me this. When you try to remember flowcharts, right, and when you try to solve questions with flowcharts, does the flowchart flash in front of you? Because that doesn't happen to me, and I think that does not happen to most of you. How you read the flowchart, how you revise the flowchart is more important, and what you retain from the flowchart is more important. What you retain from the flowchart is a concept. You don't mug up a flowchart, and I'll prove it to you. So let's see here. So this is secondary amenorrhea. Okay, she has secondary amenorrhea. No withdrawal bleeding on progesterone challenge test. Physical examination normal. Dryness during sexual intercourse, right? So important thing here is that we gave her progesterone from outside, but endometrium did not shed after that, okay? No withdrawal bleeding happened. What does that mean? That means possibly there is estrogen deficiency. The possibility is estrogen deficiency. Okay, estrogen has not acted on the endometrium, or maybe the endometrium is the problem. Or maybe the endometrium is the problem. These are the 2 reasons. Endometrium is not responding to estrogen, or estrogen is not there to act on the endometrium. These are the 2 possibilities, because she is having these symptoms, right? Now, UPT is negative. She is not pregnant. You ruled that out. FSH levels are high, on the higher side. Anything between 5 to 20 international units per liter in reproductive age group women is normal. Okay, beyond 40, more than 40 international units per liter, you call it as premature menopause, right? But that is also, premature menopause is a very serious diagnosis, right? For that also, you need to have 2 values at least 1 month apart. This is nearing that range. I'm very concerned when a woman is symptomatic. I'm very concerned when a woman is symptomatic and she has values like this of serum FSH, and the AMH is also low. AMH is also low. It's less than 1 in reproductive age group women. This age is not okay. So most likely diagnosis. Now see, low AMH just means poor ovarian reserve. Low AMH does not diagnose premature ovarian insufficiency, but yes, her entire clinical profile and the high FSH values, they are telling premature ovarian insufficiency. As simple as that. So it's not PCOS. Why? You read the question. It's not PCOS. Why? Because in PCOS, she would have had withdrawal bleeding. Withdrawal bleeding would have been present, and she would have a different hormonal profile, na? Right? And uterine synechia, if the endometrium is the problem, scarring of endometrium is there, then the hormonal profile should be normal. If so, this is not uterine synechia. There is no high risk history which will point you towards the diagnosis of uterine synechia or Asherman syndrome. Maybe a history of repeated DNCs or postpartum DNC or some genital tuberculosis like history which will make you think that there is a possibility of Asherman syndrome. That sort of history is also not there. So that's not your answer. If it's pituitary failure, then the FHS has to be low. So these are not your answers. Your answer is premature ovarian insufficiency. Let's go through this flowchart. That's why I said, you know, what do you take from the flowchart? So there's a woman with secondary amenorrhea. Okay, always rule out pregnancy. Okay, think about the common situations. Right, very common is thyroid disturbances and prolactin disturbances. So might as well rule them out in the first go itself, right? So you send for a serum TSH, send for a serum prolactin, so that by the time she comes back, she has those reports with us. So progesterone challenge test, you were asking how to give, right? So Meghal, that will answer your question. Why is it not PCOS? So when we give the progesterone challenge test, I said we give oral progesterone from outside. Okay. Now understand, if there is a withdrawal bleeding present, withdrawal bleeding occurred after giving progesterone from outside. What does it mean? Please recall what you know of the normal menstrual cycle. On the endometrium, first estrogen acts, then progesterone acts, right? proliferative phase, secretory phase, and then the hormone levels drop down, and then the withdrawal, and then the menstruation occurs, right? Now what we are doing, we are giving progesterone from outside. Why we are giving from outside? Because we are thinking maybe is not coming in from the ovaries, right? So maybe the estrogen is normal. Maybe yes, the endometrium is normal. What is the problem? Is it progesterone is not acting? Why progesterone is not acting? Maybe it is an ovulation, maybe it is PCOS. But those situations where estrogen is normal, the common causes of anovulation like PCOS or obesity by itself also could be the reason. Thyroid disturbances can also lead to anovulation occasionally, right? So, but then estrogen levels in endometrium are normal, and then withdrawal bleeding occurs. So yes, then you would think about PCOS. But if there is no withdrawal bleeding, the other possibility is withdrawal bleeding did not happen. What does that mean? That means when we gave the progesterone challenge test, withdrawal bleeding did not occur. So now I don't know. Now I think maybe it is the endometrium or it is the estrogen deficiency. I don't know, right? How do I decide further? I can go for a hormonal profile. I can go for a hormonal profile, or I can go for a estrogen plus progesterone test. Both are fine. We generally in clinical practice go for hormonal profile. Okay, estrogen plus progesterone challenge test means we give estrogen first to build up the endometrium, then give progesterone from outside, and then wait for the withdrawal bleeding to occur. I basically want to differentiate between endometrium versus estrogen deficiency, right? So now look at this. If FSH and estradiol levels are normal, there is no withdrawal bleeding even after giving estrogen and progesterone challenge test. Then what is your diagnosis? Yes, what is your diagnosis then? FSH estrogen levels normal. There is no withdrawal bleeding even after giving estrogen and progesterone from outside. What is the diagnosis? Yes, fill in the blank. This is how you're going to actively recall the flow chart. Yes, what is the diagnosis here? It's probably Asherman's. Asherman syndrome simply means that there is uterine synechia, there is scarring of endometrium. What could be the underlying reason? It could be because of post-curettage. It could be because of genital tuberculosis also. So, diagnosis is Asherman's. Endometrial cause. Very good. FSH is high and estradiol is low. FSH is high, estradiol is low. Low estradiol in reproductive age group women would be somewhere less than, I would say, low estradiol. Estradiol levels tend to fluctuate a lot. So if I have to pick one hormone, I'll pick FSH. Okay, if I have to rely on one hormone, rely on FSH. Estradiol levels during the entire month in a woman, they tend to fluctuate a lot. Okay, so estradiol levels in the postmenopausal range. Estradiol levels in the postmenopausal range are less than 20 picogram per ml. But then it's not necessary that you will always get, whenever there is estrogen deficiency, you will always get such low levels, right? So you could get levels which are fluctuating off and on. So rely more on your FSH. FSH high, remember. What is the diagnosis? If high FSH is there, what is the diagnosis? Yes, we just had it. Premature ovarian insufficiency. And if FSH and estradiol levels are low, FSH and estradiol levels are low, and a normal withdrawal bleeding happened on giving estrogen plus progesterone challenge test. If you read this line in a question, what will it mean? What do you think it means? It means, yes, estrogen and FSH are low. When you gave estrogen first followed by progesterone from outside, it was able to build up the endometrium. So endometrium is not the problem. The problem is hypothalamus or pituitary, right? So it could be a hypothalamic or pituitary cause. Okay, so one should rule out CNS tumors also. One should rule out CNS tumors also. right, in this situation, and most commonly it is going to be a prolactinoma. Most commonly it is a prolactinoma. Okay, and Sheehan syndrome will come with its own typical clinical presentation, where there is failure to lactate, and there's postpartum amenorrhea, and resumption of menses does not happen. Other hormone deficiency syndromes coming from the anterior pituitary, those symptoms will also be there. Right, so you do rule out CNS tumors, go for MRI brain, and functional HPO axis suppression is eventually a diagnosis of exclusion. In Coleman syndrome, there is congenital deficiency of GnRH. Okay, now Dr. Adityaraj, like you said, BMI is decreased, so low BMI, like you have a woman with history of anorexia nervosa, bulimia, rapid weight loss or something like that, exercise induced, she's in that low BMI zone, and this is exercise induced, stress related secondary amenorrhea, then you will call it as functional HPO axis suppression. These will all be diagnosis of exclusion eventually. FSH and estradiol could be on the low normal side also. They could be low or normal range also. They could be on the low normal side as well. Okay, fine. Now, this is a very basic and broad flow chart, right? So, when you have such flow charts, try to think along. Try to think along. And this is how various permutation combinations of clinical profile questions are asked, and so many times in clinical practice we find. Okay, next question. Now, there is a primary amenorrhea question, straightforward image based question, right? What is the diagnosis? So it's imperforate hymen, because you can see the bluish bulge at the introitus, right? So she has present to the emergency. Can you see she's present to the emergency with acute urinary retention? That is why she's been catheterized. Okay, there's an abdominopelvic lump, because that's how you go about examining the patient, top to bottom. She's not yet attained menarche, but the breast development is also normal. Local examination reveals the following diagnosis, right? So it's clear-cut, image-based question. Supposing they had given, local examination reveals a bluish bulge at the introitus, they could have given to you in writing like that also. So imperforate hymen is your answer. And it's not transverse vaginal septum. Transverse vaginal septum would present similarly, but in a transverse vaginal septum, the local examination will generally be normal, because transverse vaginal septum is most of the times it is in the upper part of the vagina. It could be anywhere along the length of the vagina, but it's usually upper. It can be in the mid vagina, it can be in the lower vagina also. So presents similarly, except for that there is no bluish bulge at the introitus. In MRKH syndrome, MRKH syndrome is Mayer-Rokitansky-Custer-Hauser syndrome, right? So this is one of the component of MRKH syndrome is Mullerian agenesis. If it's Mullerian agenesis, if it's androgen insensitivity syndrome, the uterus is going to be absent. So these are not your diagnosis. Okay, these are not your diagnosis. If there is uterus absent, then there will be no cryptomenorrhea, right? Cryptomenorrhea is hidden menses, menses collecting inside. That is what is cryptomenorrhea, right? And you are right, the karyotype is going to be XX, but usually in clinical practice, if you have such a straightforward diagnosis, why would I do a karyotype in this patient? Okay, now since you mentioned karyotype, I'll ask you another question. If there is one investigation you want to do in such a patient, what will the investigation be? Supposing the question was not an image-based question. Instead of asking what is the most likely diagnosis, they would have asked you what is the investigation that you would like to do next. Supposing the question had asked you, instead of asking most likely diagnosis, they would have asked you, what investigation do you like to do next? And they would have said, do you want to do a hormonal profile? Do you want to do an ultrasound? Do you want to do an MRI? Or do you want to do a karyotype? Now tell me, out of these four, local examination kar liya, investigation. Local examination done, investigation left now. When you send the patient for ultrasound, you want to put the probe on her abdomen first, or try to put it in the vagina first. In the same patient, it is a basic, start with a basic transabdominal sonography. They are mentioning a lump is on the abdomen, right? Isn't it? So this is, you would go for an ultrasound pelvis. Agreed. And I would prefer, in this scenario, I would prefer a trans-abdominal sonography. In this scenario, if there is a lump abdomen, I'll try to see if it is a, what is there, what is that lump. Ultrasound will reveal that it is a collection of blood inside the uterus. It will show me if there is a collection of blood inside the vagina. Basically that. That is what I want to see. I don't want to see a hormonal profile. Breast development is normal. Hormonal profile most likely will be normal, right? I don't want to see an MRI immediately. MRI I will do later. If I think that there is a possibility of Mullerian, there are certain complex Mullerian. No, see, there are certain complex Mullerian anomalies which you don't read up as undergraduate students that often. But there are complex Mullerian anomalies that can come with the, with the cryptomenoria. I mean, a transverse vaginal septum can be associated with other forms of Mullerian anomalies, like for example, a diadelphys uterus. So obstructed outflow obstruction can be there with Mullerian anomalies also. If I'm thinking about that, then maybe at a later point I'll go for a MRI, but not immediately, na expensive investigation like that. So I like to go for a basic first. Next, I like to go for an ultrasound pelvis. I don't want to go for a karyotype also right now, isn't it? So think like that. So primary amenorrhea. Let's discuss primary amenorrhea. The first thing you want to look in the question is whether the breast development is present or not. If the breast development is absent, you're thinking estrogen deficiency because estrogen is not acting, right? So write that. And breast development is present, meaning there is no estrogen deficiency. Breast development present meaning hypothalamus must be okay, pituitary must be okay, and ovaries must be okay. That is why there is no estrogen deficiency. So if everything above is okay and ovaries are okay, problem is the uterus. So the moment you see breast development normal, please know that problem is the uterus. Now for a case of primary amenorrhea, there could be possibilities where the history of cryptomenoria is there and uterus is present. Uterus is present. Now, please mind you, she is a young girl with primary amenorrhea. What kind of information, how will you know that the uterus is present? How will you know that the uterus is present, right? In such young girls, we can also go for a per rectal exam. Okay, when we complete the examination finding, gentle one finger PV we can do, but generally don't prefer to do. A gentle per rectal examination can also be done. On per rectal examination, maybe we can find a bulge in the vagina. Maybe we can find some fluid collection in the vagina. That is also a possibility. We can also feel the cervix from the per rectal examination. If we feel the cervix, that means uterus must be present. Generally. Okay, let's not go into the complexities of so many anomalies can be there. No, but generally, if we are going to feel the cervix, that means the uterus must be present. Okay, please remember that. Now, bluish, or you can go for a ultrasound. Ultrasound could give you the information that the uterus is present. Ultrasound could tell you that there is a collection, right? So, bluish bulge at the introitus, it is imperforate hymen. Bluish bulge at the introitus, it is imperforate hymen. Local examination normal, think about the possibility of transverse vaginal septum. Okay. When we think about the possibility of transverse vaginal septum, then obviously we have to evaluate with MRI. Right? All right. Next is if the uterus is absent and there is a blind vaginal pouch. Again, in a young girl with primary amenorrhea, you would know this either by a per rectal examination where you are not feeling the cervix. If you are not feeling the cervix on per rectal examination, possibility is that the uterus is absent. Possibility is that it is just a blind vaginal pouch. Okay. So, they could in the question give you information directly that there is a blind vaginal pouch, ultrasound confirms the absence of uterus, or they write per rectal exam, cervix not felt. So, these are your clues. What these clues are telling you that the uterus is absent. In that situation, if your pubic hair is present, then your diagnosis is Mullerian agenesis, most likely. If pubic hair are absent, it is complete androgen insensitivity syndrome. That is your answer. Okay, and regarding the difference between the two, they could have provided you with other options also. See, Mullerian agenesis, the ovaries are normal. In androgen insensitivity, the gonads are testes. Okay, these testes could be located in the inguinal canal, these testes could be located underneath the labia, or these testes could be intra-abdominal. The serum testosterone is in the normal female range, and the serum testosterone levels are elevated in the male range. Okay, fine, right? To confirm androgen insensitivity syndrome, to document androgen insensitivity syndrome, you will need a karyotype 46XY and Mullerian agenesis is 46XX. Okay, so again they can give you questions from this flowchart also, primary amenorrhea. So please remember this flowchart, okay, because partial means some androgens are acting and some are not. Some tissues androgens are acting, some tissues are not acting. So mainly in partial androgen insensitivity syndrome, some degree of virilization will tend to be there. Okay, in a completely well developed female with well developed breasts and everything, most likely the diagnosis would be complete androgen insensitivity syndrome. Now, next flowchart, primary amenorrhea with breast development that is absent and the uterus is present. So what did I tell you? If breast development is absent, meaning estrogen deficiency. Why there is estrogen deficiency? Maybe ovaries are the problem, maybe ovaries are okay but they are not getting signal from hypothalamus or pituitary. These are the two possible reasons. You get to know by hormonal profile. Ideally, you should be getting a full hormonal profile. Ideally, a full hormonal workup which includes these hormones, estradiol, FSH, LH, TSH, prolactin, all of this is done. But if you have to pick one, it's FSH. Why? Because FSH will guide you in either of the two directions. If FSH is high, that means estrogen deficiency is there, and at the same time FSH is high. FSH is high meaning hypergonadotropic hypogonadism. Hypergonadotropic hypogonadism, meaning ovaries are the problem. So what is the next step? Possibility of Turner's is there, but Turner is not the only gonadal dysgenesis. Problem is that there is gonadal dysgenesis. Problem is there's possibility of gonadal dysgenesis. Next step is karyotype. Excellent, because karyotype will help establish the diagnosis, right? So short height, streak ovaries, hypoplastic uterus, Turner syndrome. Maybe there is all the other stigmata is also mentioned to you. Karyotype will help you confirm. 45XO is the most common karyotype, but Turner mosaics are also there, rare but possible. Tall streak gonads, uterus present. This is other types of gonadal dysgenesis. Other types of gonadal dysgenesis. 46XX gonadal dysgenesis could be there. 46XY gonadal dysgenesis could be there. Okay, karyotype will tell you. What is 46XY gonadal dysgenesis? 46XY, I'm just writing here, gonadal dysgenesis is also called as Swyer syndrome. Neumann-Klinefelter is, Klinefelter syndrome is unaffected male person with an extra X chromosome. Okay, now, if FSH is low, coming to the next, if FSH is low, what is your diagnosis? Hypogonadotropic. Hypogonadotropic hypogonadism. Again, ovaries are not the problem. Okay, possibility is that FSH, the pituitary or hypothalamic cause is there. That is why ovaries are not secreting estrogen. Okay, so you should rule out causes like CNS tumors. One should rule out CNS tumors also. Clinically, one should rule out CNS tumors as well. One should also rule out hypothyroidism and hyperprolactinemia as well in these situations, right? Also rule out the hypothyroidism, thyroid disturbances and hyperprolactinemia as well. And if they ask you, if they mention tall woman, anosmia, the diagnosis is Coleman syndrome. Very good, Elbin. And CNS tumor could also be a possibility. See, if there is a CNS tumor, okay, In Coleman syndrome, there is just congenital deficiency of GnRH. Only that part is affected. If there is a CNS tumor, there is a potential that it may be affecting other anterior pituitary hormones also, or other pituitary hormones are also affected. So, hypopituitarism, which you read up in medicine maybe, right? So, those symptoms could also be there. And again, if there is a space occupying lesion in the brain, right, then you will have symptoms of space occupying lesion also. In the context of primary amenorrhea, the most common CNS tumor is a craniopharyngioma. Okay, so what am I doing, my dear friends? What am I doing? While going through the flow chart, I always recall concepts. Right? I always recall my concepts, and I always recall the one-liner information also. Now, if the woman is short, if the young girl is short and you ruled out everything else, right? You ruled out FSH, you ruled out all other causes. FSH is maybe on the low normal range side. It is probably constitutional. At the end of the day, it is mostly a diagnosis of exclusion. It is a diagnosis of exclusion. All right. So, this is broadly the flow chart on primary amenorrhea. Now, next question. A mother has brought her 15-year-old girl to gynae OPD and there is pubertal delay. Breast development is absent, pubic hair absent, inguinal masses are there, blind vaginal pouch is there. What could be the most likely possibility? Simply answer by eliminating. I am telling you such questions again, embryology becomes a little bit complicated to basically, for a quick recall, you need to attempt these questions by eliminating. Okay, 21 hydroxylase deficiency, that's good, because this is congenital adrenal hyperplasia, and the non-classical form of congenital could, in this profile, in this clinical context, could be a non-classical form of congenital adrenal hyperplasia. But then the karyotype is 46XX and it presents with heterosexual pubertal development. So, some degree of virilization would be there, which is not here. First of all, what I want you to understand in the question is that they are saying bilateral inguinal masses are palpable in a 15-year-old girl with a blind vaginal pouch. So, the uterus is absent most likely, that is why there is a blind vaginal pouch. Otherwise, there would have been cervix opening into the vagina. Okay. Bilateral inguinal masses, these are almost always testes in this clinical context. Okay. Breast development is absent, pubic hair are absent. Okay. Estrogen deficiency is there, androgen deficiency is also there. Basically, not androgen deficiency, I would say androgens are not acting. Think about it. I am saying androgens are not acting, right? Because androgens could come from the gonads, androgens could also come from the adrenal glands. From wherever they are coming, they are not acting on the tissues. Okay? So, now, what is the diagnosis? Yes, Swyer syndrome, uterus is present. Swyer syndrome, uterus is present. We just discussed in this flow chart. 46XY gonadal dysgenesis. 46XY gonadal dysgenesis. There, its karyotype is 46XY, yes. But the gonads, even though they may have certain testicular elements, those gonads are dysgenetic. These gonads did not produce any androgen during fetal life also. So, and these dysgenetic gonads did not even produce AMH in the fetal life as well. So, by default, this individual who had karyotype 46XY with gonadal dysgenesis, for all practical purposes, is a 46XY female with a uterus. Okay? Because as a fetus also never got exposed to androgens, never got exposed to AMH, Mullerian inhibiting substance that comes from the testes during embryological development, and that is why the Mullerian duct developed into the uterus. Swyer syndrome, uterus is present, Rat lo isko now if you cannot kind of recall. But then again, these are topics which rely on a lot of recall from your basic embryology and conceptual thinking. So, Swire syndrome, uterus is present. So, that's not your answer. Androgen insensitivity syndrome. In androgen insensitivity syndrome, okay, yes, pubic hair are absent. I agree. But what about breast development? It should be present. Why? Because all that excess of androgens that are coming from the testes, all that excess androgen gets aromatized to estrogen, right? And that estrogen acts on the tissues. But whatever androgens they are from these testes, they secrete androgens. The androgens get aromatized to estrogen. That is what happens in androgen insensitivity syndrome. Androgen themselves are not acting on the tissues, but estrogen is there, so they have these well developed breast. So this is not the answer. And like Elbin Philipp is saying, it is hypergonadotropic hypogonadism. This question had been asked in your INI-CET, and now the question, the enzyme deficiency I gave you was 17 alpha hydroxylase deficiency. This is an enzyme that is needed in androgen synthesis pathway. This is one of the rate limiting enzymes in androgen synthesis pathway. So if this enzyme is deficient, then androgens are not there. Okay, fine. Nowhere, androgen producing organs are the gonads, okay, and the adrenal glands. If the enzyme that is the rate limiting step in androgen synthesis is not there, then androgens won't come from anywhere, right? So this will also result in a type of situation where there will be a 46XY karyotype person who turned out to be a female, born and brought up as a female, and later on in life had this kind of a clinical presentation. You don't have to go into too much details. You just have to learn to eliminate the options as far as attempting your exams are concerned, right? So far that has to be the goal, and the best way to do it is go in a retrospective manner. Cement your concepts a little bit, go through the theory a little bit, right? And then whenever you find such questions, try to work out and eliminate options. So a quick flow chart: young girl with primary amenorrhea, inguinal or labial mass. They could have mentioned 46XY karyotype to you also. Please remember, if you see a uterus present in a 46XY karyotype, it is Swire syndrome. Okay. If you see the uterus absent, well developed pubic and breast hair are there, it is complete androgen insensitivity syndrome. If your breast development is absent, that means estrogen in this young girl, there is no source of estrogen. For some reason, there is no source of estrogen. Obviously, because she is 46XY karyotype, these gonads are testes. So obviously, breast development will be absent, right? But if there is no virilization, that means there is androgen synthesis deficiency. Hypergonadotropic hypogonadism. One such enzyme I gave you, 17 alpha hydroxylase. If there is virilization present, it could be two possibilities: 5 alpha reductase deficiency and partial androgen insensitivity syndrome. These are the two possibilities. 5 alpha reductase deficiency. 5 alpha reductase is an enzyme that is converting testosterone to DHT. DHT is the more potent, more active form of androgen that acts on the tissues directly, right? So if there is 5 alpha reductase deficiency, there will be symptoms of virilization. Serum testosterone to serum DHT ratio will be higher. Okay, so because of that reason, because of the excess testosterone, there will be testosterone related changes, of virilization. Fine, remember this. And with partial androgen insensitivity syndrome, this ratio of serum testosterone to serum DHT would be normal. Broadly remember this much. If you remember this much, for INI-CET, this much should be good to go. Okay, fine. Now, next question. 28-year-old woman is being evaluated for inability to conceive. That's your clue. Irregular cycles. That's your clue. Diagnostic laparoscopy chromoperturbation is done, maybe as a part of investigative workup because she's having infertility for 5 years. It shows a normal uterus and free spill of dye. What's the likely diagnosis? Straightforward question. But again, sometimes you people think that an image is given to you, so there should be something in the image. Like there are no findings of endometriosis in the image. The uterus is mentioned as normal. Even if it was not mentioned as normal, you should know that this uterus is looking normal. So it's not endometriosis, it's not fibroid. In the ovary, I don't see any ovarian cyst here. Okay, so many images of ovarian cysts we have seen, but this is not an ovarian cyst. This is most likely PCOS. You can see bulky ovaries. You can see bulky ovaries. Okay, and the feature going in favor is irregular cycles. History of irregular cycles in a 28-year-old woman. Okay, if you got confused with severe dysmenorrhea and you were thinking about endometriosis, dysmenorrhea can happen even with PCOS. All these bulky ovaries can lead to congestion in the ovaries and pelvic congestion also, and it can lead to dysmenorrhea also, right? Mansi, I think before you're seeing your question, I answered your question, right? So, anovulatory cycles are considered to be painless, that's true, but in the absence of pathology, in the absence of significant pathology. So, if there is some or other pathology, then even though the cycles are anovulatory, you could have pain. So, like I told you, with bulky ovaries, there could be pelvic congestion. Those could be the reasons for the dysmenorrhea in such patients as well, right? Now, some important questions regarding PCOS. Please highlight these for me. What is the criteria for diagnosis? Yes. Answer. What is the criteria for diagnosis? Any 2 out of these 3 are needed to make the diagnosis. This is Rotterdam's criteria. This is Rotterdam's criteria. Now, what is the ultrasound appearance of polycystic ovaries going to look like? It is going to look like this, right? The important thing I want you to point out, right, that this is the ovary. This is the ovary, and you are seeing multiple follicles arranged in a particular manner, the string of pearls appearance, the necklace appearance, and whatever or whatnot. There's also this, stromal hyperplasia that we tend to see. But it is not necessary that one always finds them arranged in this particular manner. So, string of pearls and, these necklace appearance, stromal hyperplasia, that may be there, but as a part of the diagnostic criteria, it is the number of follicles that is more important. The number of follicles is more important. Polycystic ovarian disease is actually a sort of a misnomer. There are no cysts in the ovaries. These are the follicles, the 2 to 9 mm follicles that are measured. These are not cysts. These are ovarian follicles, the small ovarian follicles that are being measured. Originally, in the Rotterdam's criteria, there were more than or equal to 12. So, maybe sometimes old examiners mention 12, you'll have to see according to the question. But new is that it is more than or equal to 20 follicles in either ovary. And or ovarian volume more than 10 ml of either ovary, more than or equal to 10 ml of either ovary. What does that mean? Means both ovaries could be polycystic in appearance or one ovary could be polycystic in appearance. It doesn't matter. Okay, 2 out of 3 need to be present. Okay. Now, LH-FSH ratio is generally more than 2:1. LH is on the higher side. If we check the day 2, generally we tend to do this hormonal profile on day 2 or day 3 of the cycle, where the LH-FSH ratio is sort of reversed. Okay, so it's LH ratio, FSH ratio more than 2:1. But if they ask you one hormone that will help you make the diagnosis, please, the hormone that will help you make the diagnosis is serum testosterone. Because according to the criteria of diagnosis, there has to be clinical and or biochemical evidence of androgen excess. So, either the clinical evidence of androgen excess is there, which is hirsutism, right, or raised serum testosterone levels are there. Okay, fine. So, if there's one hormone level which is going to make you diagnose PCOS, it's not LH, it's not FSH, it's not estrogen, no, it's androgen levels. Okay. Now, sex hormone binding globulin levels are on the lower side, and serum AMH levels in polycystic ovarian syndrome women, because there are so many multiple follicles, they produce more of AMH, more than 5 nanogram per ml. Okay, but this is not a part of the diagnostic criteria. Lifestyle modification and weight loss is encouraged for all women who are trying to conceive, whether or not they are not trying to conceive. For a woman not wanting to conceive, the drug of choice is, yes, fill in the blanks quickly. For a woman not wanting to conceive, the drug of choice is oral contraceptive pills. Any low dose oral contraceptive pills would work. Okay. Generally, in clinical practice, one tends to give those oral contraceptive pills which have, these anti-androgenic progesterones, like drospirenone-containing pills, or we have these cyproterenone acetate containing pills. But any low-dose oral contraceptive pill would work, right? Now, the first-line drug for hirsutism in PCOS is also OCPs, right? Now, if I ask you first-line drug for hirsutism in PCOS, OCPs. I ask you, now another question. There's a young girl, PCOS, with hirsutism. You gave her OCPs for, again, let's say 6 months. And generally we give for 6 months to see if, she's responding. And there is no response, her hirsutism is not better, her androgen levels are not better. So, what is the second line drug now? Indrashish, danazole is androgenic, है ना? कहीं नहीं use कर रहे हम danazole. Some time ago, when I think danazole has androgenic side effects, and it used to be given for endometriosis, and because it was it would cause suppression of the pituitary and hypothalamic hormones, and that is how it would work, inhibit GnRH and everything. And it's not used clinically anymore, danazole. Right? Spironolactone, Neumann is right. Second line drug is spironolactone. Neumann and the other, spironolactone. So, you want to give spironolactone all by itself, or you want to give spironolactone with something? The woman was on oral contraceptive pills. Please remember, these androgenic drugs, spironolactone being preferred. There are other also, flutamide and finasteride. Those other anti-androgenic drugs, A, they are expensive. Second, they have some liver toxicity, and therefore they are not the first line among the anti-androgenic drugs. So, spironolactone is preferred. But any of the anti-androgenic drugs, they have to be given along with, yes, they have to be given along with, this is a reproductive age group woman. She could be married, she could be, sexually active, right? Anything you want to give it with. So, these anti-androgenic drugs, you want to give it with something? Oral contraceptive pills. There I got the answer. Oral contraceptive pills. You don't want a woman to conceive while on anti-androgenic drugs. These drugs will if there happens to be a pregnancy accidentally. So, if there happens to be a pregnancy, these drugs will cross over and reach the developing embryo, and then it can affect the embryonic development of the potentially male fetus because of its anti-androgenic nature. So, we don't want a woman to conceive while on anti-androgenic therapy. So, they are given along with OCPs, right? OCPs also help because and the combination also works better because OCPs regularize the cycles also. OCPs, they, the estrogen component of the OCPs regularize the cycle, and the estrogen component of the pill increases sex hormone binding globulin levels also, right? So, the combination works better. So, these are the two reasons, okay? And obviously, we want the woman to be on contraception. Now, drug of choice for ovulation induction. Yes, we know this. This is an often asked repeated question. Letrozole is your preferred drug as compared to clomiphene citrate. Okay, letrozole as preferred to clomiphene citrate, but both are first line drugs. Both are first line drugs. one can use any, but if you have to pick one, pick letrozole as the answer. Second line is gonadotropins. Second line is gonadotropins, right? Now, any role for metformin? Any role for metformin? Metformin acts as an insulin sensitizer. Insulin sensitizer. Okay, insulin sensitizer. So basically, when there is some evidence of insulin resistance, we want to counter that. To counter insulin resistance, basically lifestyle and weight reduction is encouraged. That is what will go the long way, right? But sometimes, you know, women are not able to achieve their lifestyle goals. Then meanwhile, obviously, if there are clinical evidence, like for example, she's obese, she's trying to lose weight, it's not working. Sometimes it could be, there could be acanthosis nigricans, visible features of insulin resistance. Then we can give these, the agents which are like role of metformin is there. And every woman with PCOS, you know, every woman with PCOS should definitely go through a basic workup of, you know, blood pressure testing and, you know, lipid profile and OGTT, oral glucose tolerance test also, because long termishly they have these risk of metabolic complications also. So if those results show that she has any feature of metabolic syndrome or going towards metabolic syndrome, it would be a good idea to go for, you know, using metformin, but it is not indicated in each and every woman with PCOS. So that is one thing. Secondly, there are times when, and it doesn't matter if a woman wants to conceive, right? So please don't say that metformin cannot be given in women who are wanting to conceive. There are times when, you know, women are undergoing ovulation induction with PCOS. They are going ovulation induction and they have features of insulin resistance. One has tried clomiphene citrate and letrozole, maybe that is not working. And before going to gonadotropins, one want to try and give metformin also along with it. So even if a woman wants to conceive, for countering the insulin resistance, metformin can be used. So metformin can be used for those women who want to conceive, for those women who don't want to conceive, doesn't matter. Okay, right? Basic purpose is to act as insulin sensitizer, right? So remember this.